Are you able to hear me clearly? Yes. If you are unable to do that, please raise your hand and our co-host will approach you. Wishing everybody happy Mother's Day and Selamat Puasa to our Muslim friends with us here today. Raya in less than a week time. It's very soon. And now we are in Klang Valley approaching MCO 3.0. So everybody have to stay safe, take good care, and we'll do our very best to flatten our curve this time. Okay. So without further delay, let me introduce our speaker for today. After that, I will pass the floor to our speaker to introduce himself and continue to share. If you have any questions that you have not submitted to the registration form before today, you can do that in the chat box. Doctor will answer your question after his sharing. So today we are very happy to have Datuk Dr. Akmal Arshad to be with us here today. His specialty is in cardiologist, special interest in interventional cardiology, cardiac MRI, CT imaging, and preventive cardiology. He has graduated with MBCHB honours from University of Lancaster, UK. He then underwent postgraduate core medical training under the East Midlands Deanery, UK. He obtained his MRCP and trained at Tertiary Cardiac Centre in Leicester and Nottingham University Hospitals. He subsequently returned to join Institut Jantung Negara and has served the institution for more than 10 years. His post prior to joining Gleneagles Hospital was consultant cardiologist and person in charge of the coronary care unit at IJN. Perhaps I can have a doctor to share more about himself before he proceeds to his sharing today. Thank you, Doctor.
Good afternoon. Thank you, Amy, for the kind introduction. And I hope that everyone can listen to my audio clearly. And then I hope that you can access to the slides clearly, because I think the slides are extremely important. So this is tough time because it's afternoon. I think everyone is probably, this is a Sunday afternoon. It's time for everyone to fall asleep. But I'll try and get this conversation to be fully engaged. And if you have any queries, questions, or concern, I hope that you can just raise up your hand and then we can attend and answer your questions immediately. Okay. So I've been invited by Amy to give a talk on a guide to heart-related illnesses. And I think it's best to kick off to straight to the data in terms of where we are at the moment. So let me just share with the second slide. So in terms of where we are with regards to the burden of heart disease in Malaysia, if you are someone who likes to predict, and if you are someone who like to know what is the outcome in the future, then you should really look at the numbers. So this is, you probably are so familiar now with when the Trans3 DG keep showing you the not value, the R value, and the projection in terms of the numbers of COVID cases going around. And you can see in these particular slides is looking at the number of cardiac cases or heart diseases affecting the Malaysians, stretching back on the far left in 1992. And you can see how it is going into 2015 and now it's 2020. The cases are much, much higher. These are new cases reported and referred to cardiac tertiary center. And if you are someone who's going to say, what can I do to reduce the risk of heart disease? You need to look at these numbers because we are all in these numbers together. And if you look at the subsequent slides, in terms of the causes of death in Malaysia, so this is data quoted in the most recent data released by the Malaysian statistics in November 2020. And yes, of course, we are in the midst of a pandemic. If you look at the number of deaths due to COVID in Malaysia, so far it's totaling about 1,670 plus cases. These numbers are extremely worrying. But if you look at the 2020 data, it shows that the main or the major causes of death is still heart attack and stroke. So these belongs to the group called cardiovascular diseases. And how much the number is contributing? It's almost more than a quarter. In fact, this number of those people who died because of heart attack and stroke are much, much higher than a combination of a number of people who died, say, because of lung cancer, because of pneumonia or chest infection, and because of road traffic accident. So this data is in fact very worrying. And I wanted to bring you across to the end product. So if you keep getting a heart attack If you keep getting a heart attack multiple times, and the end product really is what we call heart failure, meaning the heart has now failed to work and the patient are in a state where the heart is failing. And if you look at the worldwide data in terms of heart failure hospitalization all over the world, if you look at North America, in annual admissions, so in 1 year, how many percentage of people admitted due to heart failure? The rate ranges between 1 to 3%. This is similarly seen in the European countries, about 1 to 3%. If you look at the Asian population, so like Japan is about 1.24%, in Korea less than 1%, in Australia not more than 2%. But if you look at the data in Malaysia, when it comes to heart failure hospitalization, our number is worryingly much higher, ranging between 6 to 10%. This data is released by the Malaysian Clinical Practice Guidelines in 2014. In fact, if you were to do the assessment now, maybe the number is much higher. And the number, if you can see that Malaysia registered about 3 million of hospital admission in 1 year, so annual admission. In this 1 year admission, 300,000 are actually due to heart failure related patient. Yeah, so numbers are very worrying. And what else is worrying about this Malaysian heart attack and heart failure population? So we can see that for our population, we get heart attack at much younger age. You can see here when you look at the median age of men getting a heart attack, the range age is about 50 years old. But when you compare to the European counterparts, some of them are getting about a decade later, so 10 years older than us. Not only that, and it's very important to note that these cardiovascular diseases is a range of spectrum. So if you look at on the very far left, so this is where all it begins. So it all started with atherosclerosis. Atherosclerosis is a process where you get the blocked vessels, building up of plaque inside the coronary artery. And as the diseases progress, you get something called coronary artery disease, which I will discuss later. And out of those people who get coronary artery disease, in the middle you get MI. MI stands for heart attack. Some of them get stroke. As a result of MI and stroke, there's a lot of scar tissue inside the heart muscle, myocardium, which lead to arrhythmia. So this is abnormal in terms of their heart rhythm. And they progress, and the heart muscle become worse and dilated. So that's represented by this ventricular enlargement. And eventually the patient develop end-stage heart failure, meaning the heart function has now failed. What is interesting is that all these begin with the onset of cardiovascular risk factors, as you can see, all contributed by hypertension, high cholesterol, high diabetes, smoking, and obesity. And this is those terminology that every one of us are familiar with. And in fact, it's a cycle. So you get multiple patients with risk factors, they get narrowing of the coronary artery disease, they ended up getting a heart attack, and the heart attack leads to heart damages lead to dilated heart muscle and weak heart muscle, eventually they all get heart failure. This is just to share with you that in the context of heart, it's very important organs of the body, so it acts as a pump in the circulation, and the blood supply to the heart muscle is given by these 3 major vessels, as you can see in this diagram. So we have 3 major vessels, one on the left front, one on the left back, and one on the right coronary artery. When we were born, these coronaries are completely clean and pretty, but due to various reasons, you get this buildup of plaque, and the plaque causing the lumen or the vessel pipe to be narrow. And as a result of this narrowing, you get with heart and failure. It's just another diagram to show. And what is interesting to note is that sometimes this plaque that build up, it doesn't cause you immediate heart attack. But what causes heart attack really is this concept called plaque rupture. Now, this is a new concept. If I were to tell you how do I define plaque rupture in my Malay patient, I tell them that the plaque, which is the lemak inside the vessel, it peel off the kope. The kope. It doesn't make any sense, but this is the underlying pathophysiology of heart attack. So when this plaque is peeled off or ruptured, it releases certain chemokines, which then allows your platelets, so components of your blood, to form clots. It is the clot that is inducing a heart attack because it causes a total occlusion of the coronary artery. And I'll show it to you much later in the following slide. So on the left side of the picture, this is an echocardiogram, which is an ultrasound scan. You can appreciate that in this particular patient, the heart contractility is fairly good. This is the left side of the heart, and the upper chamber here, which is slightly smaller, this is the right side of the heart. These are the valves that's opening and closing. You can see that this heart muscle is opening and closing very well. Now look on the right side. See this particular muscle, not only that it's thin, it's much thinner than the other patient. Not only is much thinner, but it hardly contract and move. So this is a scan of a heart patient who just had a massive heart attack affecting the left anterior descending artery. It doesn't take a cardiologist to appreciate that this heart muscle is not healthy. Not only that it's big and dilated, but a majority of the heart muscle is hardly contracting. And this, my friend, is a kind of heart muscle that you will see in patients with heart failure as a result of heart attack. Then the next question that you want to ask, doctor, what are the causes of this heart attack and heart failure? This is something that you probably have heard again and again, and I do not want to go through in detail because of the interest of time, but I will show it to you from a different perspective. So you'll see smoking is one of the contributing factor, obesity, hypertension, high blood pressure, diabetes, which is high cholesterol, high sugar in the body, high cholesterol, poor diet, lack of exercise. But there are also non-modifiable risk factors. So this is the one that we can't really control. This includes age. So as we age, the disease or the coronary artery problems also follow us as it progresses. In terms of sex, for male patients, so we are at more risk or at higher risk of heart disease when we compare to the women population. When it comes to genetics, so if you have a strong family history, if you ask your parents, your grandparents, there's a lot of history of coronary artery disease. So this is something that you cannot control. It is embedded in you. There's a higher likelihood of you developing coronary artery disease or heart attack. And in the context of Malaysian population, somehow the Malay and the Indian population are seen to be at higher risk of coronary artery disease, contributed maybe by the diet and by the culture. But we are also seeing that there's a higher number of Chinese population presenting with heart attack at a younger age. And this is also mentioned earlier, which is family history of premature coronary artery disease. Now, I'd like to take this opportunity to share with you some of the symptoms of heart attack. Although this is classic in the textbook, but I can attest to you that in the majority of patients who presented in our emergency department, they sometimes do not present with these typical symptoms. So the typical symptoms are chest tightness or chest heaviness. There's a sensation of pressing in nature, predominantly at the center of your chest. It may radiate to the neck, it may radiate to the jaw, sometimes at the back of the patient, and sometimes to the left shoulder and left arm. Although this is non-specific, I've seen some patients who complain of just jaw discomfort, and some probably just some sensation of nausea and vomiting. And what is important is to look at your risk factors. So if you're someone who's fit and well, you does marathon, maybe 10 to 20 kilometers of running per week, your body is very slim. The last time you check your sugar and cholesterol, they're all completely normal. There's no one in the family who smokes and no one with heart attack. If you have some chest pain, possibly it may not be related to. But if you are someone who, say, have an elevated cholesterol and sugar, the last time you had your blood pressure check, it was 150 over. You know that your body is a bit obese. You've heard of your uncle who's been admitted to the hospital. Even though these symptoms are not classic, it is worthwhile for you to get yourself checked. And I like this British Heart Foundation advertisement being posted in various places to really describe the sensation of heart attack is when you have this tightening belt on your chest. And you see the recommendation is to call 999, which means that you must present it yourself to the hospital immediately. And why is that? Time is of an essence. It's very crucial. If you have a heart attack, that means there's a occlusion of the coronary artery. That means your heart muscle is deprived of oxygen and blood supply. And the later you presented to the hospital, the more damage is going to be done to your heart muscle. And therefore, the early the presentation, the patient tend to do much, much better. Now, I wanted to share with you, this is the data from Mayo Clinic. Somehow the ladies or in women, the symptoms of heart attack is not similar to men. In fact, it's slightly different. And when they interviewed a majority of ladies who presented with heart attack, only 30% of patients complain of chest pain. In fact, much of the rest of them actually presented more with breathing difficulties. They get the sensation of fatigue. They feel unwell and restless. So this is something that they cannot explain. Nausea and vomiting, cold sweats. Sometimes they do feel slightly lightheaded and giddiness. So we call these symptoms atypical, which is not common. So 71% just general feeling of lethargy or fatigue and no energy. 42% complain of shortness of breath. Nauseated about 39%. Cold sweats about 35%. Only 30% of the ladies who presented with heart attack come in with chest pain. What it means is you need to go and get yourself checked if you have any of these symptoms. Reason being is because if you look at the data at the hospital, when it comes to ladies with heart attacks, so in hospital mortality, meaning death for women, it's actually much higher. The 9% women, there's a highly likelihood of them developing heart attack and died when compared to men, which is just 4%. And the reason being is because I suspect it's because of the symptoms are atypical. So sometimes maybe the women presented very late because they don't think that the symptoms are related to heart or heart attack. And the doctors also probably see women as someone who probably won't get a heart attack, so they downplay the symptoms. They somehow downplay the symptoms. So there is a somehow late presentation and late intervention by the clinicians. It is important to note that for women, there are a few factors that contributed to this higher risk of heart attack. And one of it is menopausal age. So before you reach menopause, you are protected by the hormones. But as soon as you reach menopause, the hormones is no longer there to protect you. So the risk of heart attack for postmenopausal women is as much as men. Number two, it is interesting that in terms of the epidemiological data, there are higher numbers of women presenting with hypertension at younger age. This is very unique. In fact, in my clinic, I see a lot of women at working age, between the age of 35 to 45 with high blood pressure. Maybe it's contributed by stress at work. And we see a lot of the groups are predominantly teachers, predominantly those who work in banking institution where there's a lot of pressures going on and there's a family to juggle. And some of these factors play the role into contributing to the development of hypertension. There's also a higher rate of hypercholesterolemia in menopausal women, diabetes, and also a combination of metabolic syndrome. Now, just coming into this issue of obesity, in fact, I would like to share this with you. If you can see in the chart, I mean, I've discussed this before with various places, that sadly for Malaysia, we are number one when it comes to obesity, when you look at the rate of obesity in Southeast Asia. So we stand at the very top at about 44.2% for obesity in population. And you compare that to our counterparts. So let's pick up Indonesia, for example. So it's only 21%. Go to Laos and Cambodia, just hardly 12 to 13%. I think the one is catching up with us is Thailand and Singapore. And of course, this is the biggest contribution for heart attack and heart diseases. And not only that, I think the body waist to hip ratio also plays an important role. There's enough data to show that if you have truncal obesity, meaning you have a lot of fat, adipose tissue, predominantly at your abdomen, a lot more than your hip. So this is what we call the apple shape versus a slimmer abdomen, which is the pear shape. In fact, there's a higher risk of the presentation of heart attack and heart disease. And sometimes when you see the doctor will look for physical signs associated with heart disease. I just wanted to share with you, because now It's actually very difficult for us to meet each other in the event of a lockdown, and also the issue with COVID. But there's a lot more usage of online virtual connection, and maybe this is something that you should focus on. So this is called xanthelasma. So if you look at this particular slide, so this is what I wanted you to take note also. So xanthelasma is these deposits of this yellow. Sometimes it actually feels very soft around the eyes. Sometimes people thought that this is a curse. It's not. So this is one of the example of a patient with extremely high elevated cholesterol that you can look for amongst your family members. And if you see this, you should recommend them that they should go for an assessment with blood test to check the level of their cholesterol. And I have had a encounter with a number of patients whom, when we reduce the amount of cholesterol over the years, gradually this deposition of fat under the eyes also disappear. Under the eyes also disappear. This is something called corneal arcus. So if you look at the colored part of the eyes, so there's a white rings circulate around the eye structure. So this is called corneal arcus, and again, this is associated with the presence of high cholesterol level, which you can confirm later with a blood test assessment. So this is another swelling at the back of the ankle. This is known as tendon xanthomata. This is also associated with elevated cholesterol. Okay. Now this is the other interesting part. So if you look at the yellow, so there's a lot of data also being shared, although this is not 100% specific and sensitive. The presence of these yellow creases, you can see that small little line there, somehow is associated with the presentation of coronary artery disease. So I'm not saying that if you don't have this, you may not have a heart problem. This is just some of the features that the doctors look for when we look at the physical examinations. Now, when it comes to investigation, I think investigation is very important. And the reason being is, as I've mentioned before, some of these things that we have talked about actually don't have symptoms. So for example, high cholesterol, you will not have any sensation or feeling when you have high cholesterol. Diabetes maybe. So predominantly the symptoms for diabetes is polydipsia, meaning passing a lot of urine, feeling very thirsty, polyuria, passing a lot of urine, and feeling lethargy and tiredness, especially at night time. But for hypertension, there is no symptoms. So one of the few things that we do when we assess patient for heart disease is we do this test called ECG. ECG can give us quite a lot of information. So ECG is a non-invasive test where we place a lot of these chest leads on the chest, and then we produce this graph or chart looking at the signal of the heart. Now, this signal is not good in someone who presented with chest pain and they come up with this signal. In fact, this is an ST elevation, also known as the tombstone sign or the widow's maker. Why is that? Back in those days, when you have this particular signal, it means that the major vessel of your coronary artery is blocked or occluded. When it's blocked, those days, there's no treatment. I think back in the 1930s, really there's no treatment in terms of blood thinning medication, in terms of lytic therapy. So those days, if you are presented with this kind of ECG, they will put you at the very end of the hospital room and they will call the priest because the likelihood of you surviving is very poor. And nowadays, if you have this kind of ECG presentation, you'll be bombarded and loaded with blood thinning medication. You'll be taken to the cath lab, angiogram. The doctor will then open up your blocked vessel, aspirate all the thrombus that's causing the blockages and implant a stent to allow a good passage of blood flow. So what you want to do is to have this ECG done and taken, at least you can have an information in terms of the causes of your chest pain. Number two is we always perform blood tests. A blood test is not just to check for the presence of heart attack, in which we do a cardiac enzyme. There's a special cardiac enzyme called troponin, in which this troponin will go very high as a result of a heart muscle that is dead or damaged, which will guide the doctors in terms of diagnosis heart attack. But if you come in at an assessment, the doctor will do fasting sugar and HbA1c. This is to check for the control of your sugar. The doctor will check for the presence of high cholesterol, will check for kidney function and blood counts, kidney functions and blood counts. What else can you do? So in someone who do not have symptoms, sometimes we can try to detect the presence of blockage or coronary artery disease much earlier and much sooner. And how do we do that? By enticing and see the changes of the heart when we stress the heart. So what does it mean by stress? We stress the heart by getting the heart rate to increase. So in this situation, we put patient on treadmill, we increases their heart rate, and when the heart rate increases, the doctor will then look for the changes on ECG. There are specific changes. So if you look at these slides, it is stated the ST segment depression. And what it means is if you were to run on treadmill and we increases your heart rate, say from a baseline of 80 to about 150 or 170 beats per minute, if we do not see these changes, then we say the patient does not have evidence of narrowing or blockage. But if we detect this ST segment depression, which are the changes that is suggestive of a narrowing, then we make a diagnosis of a narrowing or a coronary artery disease. And the patient will then require to go for coronary angiogram after a positive stress test. Other tests that we can do, as I showed to you earlier, is an echocardiogram. So this is a non-invasive test. This is similar to the pregnant ladies assessment, where we put gel on the chest and then we use an ultrasound probe, and then we look at the degree of contractility of the heart muscle. In someone whom the heart is healthy, we can check for the size of the heart. We can see how good the opening and closing of the valve. We can see how healthy the contraction of the heart muscle is. In someone who already have damage due to heart attack or coronary artery disease, the heart muscle tend to be much weaker and doesn't contract together. So we do stress tests together with an echocardiogram. This is a bit more sensitive at picking up blocked vessel rather than stress test alone. In some individuals, if they cannot manage to run on treadmill and they cannot do much of the treadmill exercise due to limitations, say due to knee pain or back pain or some other limitation, these are the kind of patients that we may send them for CT scan. Now, if you compare the CT scan now and compared to CT scan back in those days, the CT scan now gives us better resolution of the pictures of the coronary arteries. In terms of the issues with radiation, is a lot less. Normally, we detect this radiation amount by measuring the amount of millisievert. So I recall back in those days, so maybe 10 to 15 years ago, the amount of radiation is as high as about 10 to 15 millisievert. Now, with the advancement in the technology of scanning, we can reduce the radiation all the way down to 1.5 to 2.5 millisieverts. You can see it's actually very significant reduction in terms of radiation exposure. And at the same time, we're able to detect the presence of coronary artery disease. So just wanted to share with you, when we give contrast or dye or color to the patient, the color will then flow into the blood vessel. So on the graph that's showing A, so you can see that in A here, the vessel looks completely healthy and clean from the very top to the very bottom. Whereas in the other patient, you can see that there is a presence of plaque. Now, this plaque usually made up of various components, so fat, sugar, cholesterol, bad tissues, inflammatory tissues, and cells which have been building up over the years. So you can see there are two components. So there are the black color. So the black color usually is soft plaque. The white color, these are usually full of calcium, meaning it's been there for many, many years. And sometimes you can see it's a combination of both. So when we do a CT coronary, not only that we can detect the presence of plaque, but we can also see how severe this plaque can cause the narrowing to the lumen of the vessel. And we can assess this not only in one particular vessel. We look at all the major vessels. So here you can see the left side of the coronary artery, including the side branches. This is the one at the back called the circumflex, and the branches called the obtuse marginal. And then this is the one on the right, coronary artery. There are also other assessments. This is called the cardiac MRI, and this is one of my main interests. But we usually don't do this cardiac MRI as a first-line treatment. But this is one of the option if someone says, doctor, I do not want to go through CT scan because of concern with radiation. So cardiac MRI has got 0 radiation, and yet it gives us a detailed information in terms of the heart function and how good the blood flow into the blood vessels. And the thing about the cardiac MRI is that the pictures component are much clearer. So you can see this is a 2-chamber view of how healthy the heart contraction is. This is in a 4-chamber view. We can also see the movement of the blood in the chambers and the opening and closing of the valve leaflets. We can measure how much is the cardiac output. And in fact, we can give a special contrast called Gadovis to see how healthy the heart muscle is. The cardiac MRI is one of the advanced imaging to really look at how healthy the heart muscle or to detect any abnormal heart muscle disease at early stage. Okay, so I hope by now you would have picked up one of the concerns in terms of why heart disease is very important, because these are the contributing factors of the majority of death in our country. For our population, those people who develop heart disease and heart attack occur at much younger age. You have seen how damages heart coronary artery disease can be to individuals when it comes to how it causes a heart dilatation and in fact causing a heart failure. You can see that the symptoms, now you know the symptoms of heart disease and what are the risk factors. So these are risk factors that can cause someone to develop a coronary artery disease or heart attack in the first place. And I've shown you some of the physical signs and some of the investigation that we can do trying to detect coronary artery disease. Now I'll share with you some of the options of treatment for coronary artery disease. Although it's quite nice for cardiologists to perform all this treatment, in fact, it's actually much nicer if we can focus on prevention, because it's quite sad to see Malaysia having one of the highest number in South Asia. Is certainly not something that we should be proud of. So just to share with you, if you presented to the hospital with chest pain and the doctor performed an ECG, and the ECG shows an evidence of heart attack, and the doctor took some blood, and the blood test also showed that the cardiac enzyme is elevated called troponin, that is already making a diagnosis of heart attack in that particular patient, also known as myocardial infarction. And in this situation, the aim is to initiate patient on all the tablets for treatment. So we give them blood thinning medication. You probably have heard of cardiprine or aspirin as a blood thinning medication. You probably have heard of Plavix. You probably have heard of statins. So medication like atorvastatin or rosuvastatin, Lipitor, Crestor will all be initiated to try and bring down the cholesterol level. If the patient is diabetic and the sugar is poorly controlled, they need to control the level of the sugar, and some patients ended up needing insulin to control their sugar level. The next step is to check the coronary artery in greater details, and for this we perform coronary angiogram. So coronary angiogram is a procedure where we put in tube. I think back in those days we used quite a lot of access at the groin. So here in the femoral artery is also connected to the heart. But now more and more doctors are doing the procedures on the wrist, so the right radial. This radial artery is also connected all the way to the heart. This is just a diagram to show, and I just wanted to share with you, this is the setup in someone who's having a coronary angiogram. So you can see here my patient lying there, that's me, and then you have a scrub nurse who helped me to pass the items that I request. Then I have my radiographer who will be sitting at the very edge of the table, and he or she will help me to control the x-ray. So you see at the top of the head of the patient, there is this white box, and this white box is actually the x-ray that moves around the patient chest to take a picture. So these are step by step on how I perform a coronary angiogram. You can see that there is a small syringe there with the smallest needle find in the hospital is a brown needle. So we will first give local anesthetic to the wrist. The anesthetic agent is lignocaine. When we give this lignocaine, the wrist will become numb, so that the subsequent injection, the patient will not feel much. And then we will insert this radial sheath. So it's like a short tube where we place it on the wrist during the procedure, and this become the portal where we can put in so many things through the vessel and into the heart. So you can see that here the radial sheath has already been inserted, and then this is the long tube called the catheter to be inserted into the patient. And this is the white box that I mentioned to you, where the white box can move up and down around the patient's chest to look at the vessels. And you can see here me injecting the contrast or color into the vessel. So just to share with you, first, when we inject, we will try to identify where's the vessel. So when I put in the needle, I'm waiting for the blood to dripping out, so I know that I'm actually in the vessel. Then I will put in this small wire. So this is called the guide wire. The guide wire will then enter the wrist of the patient. And then using the guide wire, I will then put in this sheath. It's like a short tube. And this short tube will be left inside the patient wrist during the procedure. You can see that there is a hole there. And that's where the hole that I put in more stuff inside. So here there is this longer catheter that I put in. Normally we don't put the catheter blindly. We put the catheter with the wire. So you can see I'm shoving in the wire through the tube. And throughout this procedure, patient will be awake. In fact, the patient can be chitty-chatty with me. We can talk about all things in life while doing the procedure. And I will look in front of me. There's a screen. And then you can see my wire going through. The silhouette here is actually the heart. And then the wire will then engage to the blood vessel. And when I inject the color will fill up the blood vessel and it gives you this particular pictures. This is called the angiogram. And if you look at my cursor here, this is the point of the narrowing. There are 3 areas of narrowing in which the signal of the color become narrow, tapered. That is where the point of the narrowing is. And if we were to find narrowing of the coronary artery, immediately we will perform coronary angioplasty. So if we put in wire and balloon, the balloon will be connected to a hand pump. The hand pump will then be inflated. The balloon will then expand. We don't remove the plug. We just compact and push it to the side. And then we put in another balloon with the metal on top. And this metal is called the stand. And we inflate the balloon. The balloon will then open up the stand. The stand, based on the engineering marvel, it will open up rigid and keep the plug away from the major lumen, the main lumen. So now the vessel that is initially narrow is able to be kept open. A lot of patients ask what happened to the metal. Metal will then be part of the vessel wall over the months and years. It will stay there throughout. I just wanted to share with you some of the sample of cases that have come in to me. And this is as young as 31 years old. So this is a case of a lorry driver who's very smart. So he's only 31, but he had a chest pain and decided to stop his lorry and then go to emergency department. And I am the one who attended to him. So we did an ECG. So there are some changes to suggest a heart attack on the leads supplying the right side of the heart. And then we took him to the cath lab, which is our angiogram lab, and we perform a procedure. And true enough that there is a heart attack that is ongoing with the narrowing. And you can see that this particular part looks very hazy. It's because of the presence of thrombus and clot. So this is the part that we wire. Then we suck out the thrombus using a special device called thrombuster. And then we deploy the stent. You can see the picture after the stent deployment. So the blood vessels are opened up and the blood flow can resume. These are the example of thrombus that is aspirated in this particular patient. And it's very, very humble experience for me as a cardiologist. Sometimes I see all these patients, then I say the thing that kills them or going dot there. And this clot is the one that is causing an occlusion of the coronary artery, causing problem with the blood flow. As a result, the heart muscle is deprived of oxygen, which will then lead to chaotic rhythm of the heart. So this is called the VT and VF, and this is the one that usually causes the patient to succumb and die. And when we do this, it's in fact a very humble experience, because such a small thing can cause so much hassle and trouble to the patient. And this is the one that I will discuss with you later. What can we do from today onwards, not just for ourselves, but for our close relative, family and friends, in terms of let's not end up in this picture. Let's all try not to get up to the level that there is a need for an angiogram. Sometimes I see thrombus this amount, but I can share with you some of the cases where thrombus is just too much. So we keep sucking the thrombus, the blood clot again and again. And these are usually in an extensive heart attack situation. And just to share with you, how does the stent looks like? So the stent deployed when it's crimped on the balloon. So this is the stent before it's being deployed. This is the stent after deployment. You can see it's actually much bigger. The stent are usually made up of metal that is inert to the human body. So usually we will use either platinum or cobalt, chromium. Back in those days, we used quite a lot of stainless steel, but stainless steel tend to be quite rigid. So a combination of platinum and cobalt, chromium are of choice and preference these days. This is just to show you the balloon. So balloon comes in different shapes and sizes. So it will be the cardiologist who will decide. See the hand pump, it's just a plastic hand pump, looks like the one that you used to pump your balloon party or nila, but of course this is the medical grade. You can see that the balloon started to inflate, and the inflation is based on the amount of pressure that we apply upon. And this is in atmosphere, so 6 or 8 or 10 or 12 atmospheres. And the balloon sizing, it depends. So if the doctor do the angiogram on you, the doctor say, the vessel looks like 3 millimeter, then we will pick up 3 millimeter balloon size. If the balloon size, if the vessel size is 2.5, then we will pick 2.5 millimeter. So this is very important for the cardiologist to do the sizing. Just like how you make your suit, must be suiting you very well. If you put a big balloon in a small vessel, that's when the vessel can damage and tear. So these are the one that's very important. Just to show you also that not all cases can go through stenting. You can imagine that now you probably have heard the term called cabbage or bypass surgery. So bypass surgery is an open heart surgery. So if you look at this picture, so this metal structure here, this is the retractor. So the surgeon will then open up the middle part of the chest and retract the chest open. Now that the chest is open and hold in place, the doctor or the surgeon need to identify where's the natural vessel. So you see this pink structure here. So this pink structure is actually the vein graft, the one that I'm pointing, the vein graft. This is sutured, so it's stitched, like how you stitch your pants. But this is of course micro stitching with the special glasses that they use to the vessel. And this vessel size is very small. So you can imagine if you have a ruler at home now, the majority of Malaysian blood vessels is between 2.5 millimeter to 3.5 millimeter. So very small. So it's a microsurgery. And the surgeon will decide how many grafts that they need to do. So sometimes you see or you hear triple bypass, quadruple bypass, 5 vessel bypass, 6, 7 bypasses, depending on how many vessels that the surgeon can graft. This vein graft usually is harvested from the vein in the legs. So sometimes depending on the amount of bypass they need to do, they may take 1 leg only. But if longer, they take 2 legs. If much longer, they sometimes use or harvest the right radial artery, so the artery in your hands. Quite an extensive procedure, but of course, nowadays the procedure for bypass in utilities and devices in terms of much smaller, in terms of recovery is much faster, in terms of the duration of the surgery is also shorter. Expect to stay in the hospital maybe between 7 to 10 days before being discharged. Time patient resumes normal. You have vessels and you so failure, this is weak. There are also situations where the heart becomes acting in synchrony. So in heart weak, that we may have to put in a battery like this, an extra of say 3 to 5% more, so that the patient doesn't become too tired or breathless. I think enough of talking about what we can do to treat. I think the key here is the prevention. So I think prevention is much superior than cure. This is the one that I always encourage, and we should really share this. What can be done? I think you've heard. So the key here is knowledge. Knowledge will, if you arm yourself with knowledge, then you spread the knowledge to others. Without knowledge, it's very difficult, and knowledge is depending on the data. So whatever we do and practice today is all based on what has been done in the past and what works and what don't work. So this is the recommendation. You know that a lot of these risk factors don't have symptoms. So hypertension, high cholesterol, high sugar, this doesn't have much symptoms. By the time you have chest pain, that is already a point where there is already a significant narrowing of the blood vessel at the coronary artery. By the time that you presented with shortness of breath and swelling of your ankle, you're already at the stage where the heart has already failed. And this is the part that we should not wait up to that point. So these are the things that you can do. Consider yourself when you are at home. Maybe it's worthwhile to have a blood pressure machine at home. Why is that? Because you can check your blood pressure, not just for you, for the rest of the family. And this is very easy. Check cholesterol and sugar level. You don't have to do this much often. Maybe if you don't have much time, you can do it once a year or once every 2 years. And if there's anyone who's smoking in your house, maybe this is the time that you need to encourage. There's a lot of data that shows by just cutting down from 20 cigarettes to 10 cigarettes per day to 5 per day, the risk of a heart attack and heart disease reduces exponentially. And then exercise regularly and maintain a healthy diet and healthy weight. So this is what I recommend you should have. If you don't have any weighing scale at home, maybe you can consider having this as a gift or buy this for your household. It's always important to check on your weight, because without parameters to monitor yourself, and this one you don't need to come to the clinic. This one just for you. Put it in the house. So make it a normality. After you take a shower, the first thing you must do is check your weight. Gives you an indicator whether you can eat a bit more or should you eat a bit less on that day. Reminds you maybe you need to do a lot more walking and take the stairs at work rather than to go on the lift. So if you see that your weight is coming down, then maybe you can go for cheat day. If you see weight is going up, you can go for cheat day. If weight is coming down, maybe weight going up, then you need to remind yourself maybe to give some excuses when your friend asks you to go for those buffet, which now you can't go lah. But before you press on the apps to order your Grab food and Food Panda, maybe weigh yourself first, and then you decide what is the best thing to order. Okay, number 2 is a measuring tape. As I've shown to you earlier, that one of the biggest contributor for heart attack in Malaysia, at least, is the rate of obesity. And the obesity is not just a general term of obesity, but we're talking about truncal obesity, which means the deposition of fat around the belly, around the stomach region. And it's always important to measure your waist circumference and your hip, because if your waist circumference is much wider than your hip, therefore it put you at risk of heart disease. And this is something that you can measure. I know that sometimes some men, as we grow older, we go to the tailor, we ask them to put the rubber on our pants, so that as our waist expand, we don't have to worry too much about it. But that's not a good thing. So make sure you know what is your waist size and monitor yourself. All right. These are blood pressure machine that you can buy at home. Share it with your colleagues. Do blood tests. Maybe once a year is sufficient. If you say, I don't like being stabbed, maybe once every 2 years. At least this gives you a feedback. If your cholesterol, LDL, and TG is sky high, this is something that you need to work on. Balanced diet, quit smoking, And then I think most importantly is to participate in health event and public education. So there's always a new information and data that keep coming through. There's always new treatment available. There's always new things that comes into play. There's always new risk factors that may set in. Without participating in health event and public education session, that means you are allowing yourself to go out there without knowledge lah. And without knowledge meaning you are blinded lah. So no direction, which is not good. I think even in our life, forget about health. I think even in terms of financial status, how can you leave it to chance? You must already predict how much is your earning, how much is your saving, what can we do when we retire. All these are already come into play. And without knowledge and by guessing, you are really doing yourself a disservice and not helping yourself at all. Okay, so this is just to share with you of the heart specialist clinic at Gleneagles in Tower B, just to show you some of the setup when they come. But anyway, I'm gonna end that talk now because I think we are already reaching the end of the time, and I hope everyone can pick one or two information and share it with your loved ones and your family. And I would like to thank Amy and Serena organizing this event. If you have any particular questions, please put through, and I'll try my very best to answer your queries and concerns. Thank you.
Thank you. Thank you, Doctor. Thank you, Datuk Dr. Akmal Arshad, for your presentation today. It has been very fascinating because I have clients who went through angiogram, and then they have stent and even heart bypass. I think the video that you show is very beneficial, and I was very fascinated watching the video. Thank you so much for sharing. Like I mentioned earlier, that if you have any questions that for our doctor for today, you can put into our chat box. Now let's move to the question that we have from our registration form that we have our attendees submitted earlier. The first question is for doctor. If a person often has a stressful working life and often lack of sufficient sleep, is he or she at high risk of heart attack?
Okay, so that's
he
a very
or she
good
is
question.
In the late 30s.
Yeah, so that is a very good question. A lot of people ask me, can stress cause a heart attack? So it's not directly. So in the sense that if you are very stressful in terms of your life, it's not going to cause the building up of the plaque inside the coronary artery, the one that I showed to you earlier. It won't. But there's a lot of data that shows that stressful lifestyle has contributed to poor lifestyle. So stressful situation makes you become a person who lead a poor, unhealthy lifestyle. So what it means is you're probably not going to get enough sleep. Too much stress, your blood pressure then goes up. When your blood pressure goes up, enough sleep, it becomes into this vicious cycle that you're not going to eat very well. So you're not going to wake up going for your routine half an hour walk and exercise. You're not going to sit at your dining table eating a vast oatmeal. You won't. You probably will skip your breakfast, and then during lunchtime, because of stress, you probably take up smoking, and then you probably go out with your friends, because it's the time for you to relieve your stress. And when you're stressful, you probably do not know or be aware of what you're eating. Anything that you eat give you this false comfort. The more you eat, like ice cream, some people will binge on ice cream, some people will binge on sugary food. Some people, when they're stressful, they say, I need a box of donuts. And then they go home, no exercise, they probably will be drinking alcohol, just as a way to calm themselves down. And then this cycle of lack of sleep, poor diet, no exercise, high sugary and high cholesterol food intake, put them into this cycle. I can tell you, at least 2 or 3 weeks ago, there's this funny week that I had. I know it was a lockdown, but I had a lot of patients who comes in and they're all very young, and the concern was high blood pressure. So when we checked, the blood pressure was as high as 180 to 190s in the clinic. Do you know what was my treatment for them? So I noticed that they are all stressful at work. So some of them work in the banking institution, some of them work in the academic or education institution. So I can sense, based on what they've told me, there's too much pressure The problem with me is I cannot give you tablet to relieve your pressure. Neither I can give you tablet to your bosses to make them less forceful or pushing you to perform. I can't. I can't. So sometimes what I do is if the blood pressure is too high, I give them MC for 1 week. And then I told them to do blood pressure monitoring at home. And interestingly, the blood pressure comes down nicely. I give them a standby medication for blood pressure medication. I think majority up to 80% doesn't need to take those medication. What it means really is that if you come into the hospital or to the clinic with high blood pressure, actually you need to also check your blood pressure at home. Because too much stress at the hospital, at the clinic, at the workplace, push your blood pressure high and goes into the cycle. And sometimes what you need to do is to stop, think, what can I do differently now to bring down the blood pressure without medication? And this is some of the other interesting topic that I've given a talk in the past. Can we reduce blood pressure without medication? The answer is yes, but only in those groups. If they tell me at night time they will drink 2 glasses of whiskey, they will smoke at least 5 cigarettes or 10 cigarettes per day before they go to bed. And then when you weigh them, their body weight is 98 kg, 104 kg, and they used to be 60 or 55 kg before. And when you interrogate their diet, because you are stressed, no time to cook. So what do? Drive through. There's so many drive through. I mean, I'm going to share. I live in Taman Melawati. If you come to Taman Melawati along the MRR2, there are 8. I've counted 8 McDonald's branches drive through along. I cannot believe it. I mean, it's side by side. So if you come to near the TAR College, near Taman Melawati, there's side by side McDonald's on one side, which is on my side, and there's another one on the opposite side. Like seriously, there's like not enough. And whenever I pass through, I always see a queue. What it means is these are people who are very stressful, no time to cook. The fastest way to eat is fast food. Fast food is rich in and rich in cholesterol. These are the one that drives you. So eventually, if you maintain and sustain this kind of lifestyle, that you don't break the cycle, eventually you will get heart attack and heart disease. I hope that answers the question.
Yes, very well, doctor. Because you mentioned that when a person is stressed, their lifestyle change. You are right. They will just grab whatever they can find, comfort food especially, and they probably skip a lot of meals. And to reduce stress, that's when they smoke more. Some of them who drink more. And I think this not just at a young age. It could be at any age.
Any age, yeah, correct.
Yeah. And when you mentioned that to have immediately, which is weigh your weight, and also check your blood pressure. I think that's very good. Take note to be taken now. Okay, second question. Read of cases that people drop dead while sporting, like badminton game, which is considered a sport. Actually, we have a few similar questions. We have about badminton, golf, okay, and also I think on a marathon, on a running. So, doctor, what's your comment?
Okay. So I've also had a separate talk on this. I think this requires a proper talk, but I'll try to answer it in a very schematic way. So it is not uncommon. In fact, if you remember during PKP1, total lockdown, nobody can go exercise. In fact, if you go exercise, you get cursed. Someone will put you on social media, and then eventually they loosen it up, and people can start taking up sports. It was during this time that if you notice on the newspaper that there's a lot of cases where people were found to be drop dead. And in particular, there's a sport called road cycling. Because people can't go for holiday, they can no longer take flight. And they have some money lah. They say, let's buy some road bike. So they go start buying road bikes. So this is called I call them the mammals lah. So the middle-aged men in Lycra. So suddenly at the age of 45, 50, they want to feel young again. Since they can't go travel, can't meet up with their friend, all the kopitiam are closed, let's go cycling. That's the only excuse to go out, right? So when they cycle with their buddies. Some of the buddies are actually regular cyclists. They've been cycling a long time. And you are new, the newbies come in and join. And they will try to take up all the nice scenic route of cycling. And these in particular are usually always the one with the climb. Genting Sempa, Perez, these are all the places where people go cycling. It's green, it's good, there's a climb. What people fail to realize is that the climb take a lot of effort for you to pedal. Not they may be obese or maybe they're overweight, they never train and they go pedaling without knowing that they actually already have an underlying heart problem. So there's a lot of data that shows even in a sudden cardiac death in athletes, they divide it into two groups. So those below 35 years of age and those above 40 years of age. In those who are above 40, if they drop dead when they are doing training or athletes, the majority of cases are caused by coronary artery disease, meaning blocked vessels. Why? Because these are the prime age. You probably have an undiagnosed cholesterol. You don't know you have diabetes. You don't know you have been smoking. There's already a blockage, and now what you're doing is just push yourself up to a point where the heart is deprived of oxygen and blood supply. And usually during this period, because we are tropical country, they probably are dehydrated. They are not eating and drinking very well as up to the demand of the exercise. All this trigger for the clots to form, and then they collapse and had heart attack. And sometimes also I notice that they already have symptoms, meaning when they cycle or when they jog fast, they already have some chest tightness or breathing difficulties. But you know, when you cycle in a group, you will downplay all your symptoms. You will say, no lah, I have ego. I cannot be finishing last compared to my other colleague. I need to show that I'm also equally strong. So they push themselves. But it's not pushing themselves too much is the problem. It's the problem of not knowing that they already have heart disease. So this is my recommendation. If you have never maintained a healthy lifestyle, so for example, maybe back in university days, you go for sports and athletes, and then you start working, and then you have family, and for the 10 years, you never do any regular exercise, and now you just bought a new bike. Don't tell me you're going to go straight up and cycle up Genting Sempah. That's not the wise thing to do. The wise thing to do is after purchasing your items and bike and all your gears with your Garmin and all your baju and all, is to go get yourself checked. What do you need to do? Simple. Go run on stress test. So you go to the clinic and do this treadmill stress test. If you run and the doctor push your heart rate as high as 160, 170, and there's no signal of heart block, that means it's safe. That means you can go and join your colleagues. The problem with all these individuals is they go out not knowing that they may have an underlying heart disease. Now, the other group who are below 35 years of age, these are the special one. These are the one that have something called congenital related heart disease. Maybe they are born with it. So if you are someone who's going to go for competitive sports, so I know now it's lockdown, but even in lockdown, you can still go for competition in the virtual arena. So, you know, you can go in front of the computer, connect your bike or connect your treadmill to the computer, and then you can run. There's a lot of apps called Strava and all this. You can go run or cycle with your colleagues in other parts of the world. So this is another danger for very competitive sports. It's also important for you to get yourself checked. And it's not that difficult. Usually in a checkup like this, doctor just need to make sure that your cholesterol is not high, your sugar is not high, check your blood pressure is normal, put you on stress test. If the stress test is also normal, that means you're quite fit and well, you can resume your activity. So the message here is quite clear. If you are someone who never get yourself checked and tested, and if you're going to go out there and do competitive sports and exercise, I think it's a wiser thing to get yourself checked first. I hope this answered the question.
Okay, yes, I guess definitely, because there are a lot of people that we, you know, some of them probably heard or met personally that suddenly pass away due to heart attack, due to excessive sport. I think it's because they themselves didn't know that they had an issue and for not getting checked first. But for someone who have been exercising regularly, let's say this person have been running around every day or maybe every other day, and suddenly that person had a heart attack. Do you contribute that to maybe a congenital issue, or maybe the person does not realize that?
So again, it depends on the age. So in someone who's very, very young, and we see this quite a lot. So that's why if you look at the, even if you remember, so there are many news before involving professional athletes. So professional athletes, these are the ones who really compete from the young age. So they probably attended a sports school or sports institution. They represent their countries at the national level. And then when they play football, suddenly they collapse and die. So there are 2-3 conditions that can cause this, affecting the pure fit athletes. So one is called hypertrophic cardiomyopathy, which means that there is a thickening of the heart muscle that is so abnormal. So the heart muscle become thickened, and not only is thickened, the muscle become fibrous, so the tissue of the heart muscle damaged, making them susceptible to dangerous heart rhythm. And this dangerous heart rhythm, also known as ventricular fibrillation or ventricular tachycardia, and this is sometimes can be exacerbated by strenuous activity. But the diagnosing in those sports athletes, professionals, usually will involve echocardiogram and cardiac MRI. So I would say it is not saying that too much exercise will put you at risk of death. Usually there's always that underlying causes of abnormal heart to begin with. And that's why I think there are two spectrum of patient here. Or individuals. If you are someone who's really going to go at the competitive level and you want to do exercise regularly, seriously, there's no harm in getting yourself being assessed either in the method of the stress test or echocardiogram to make sure that your heart is actually fit. And in fact, nowadays, the Olympic Association even come up with the guidelines in terms of how all these countries should assess their athletes, and especially those who are competing at the national level, in terms of what are the screening requirements. I think this awareness in terms of a sudden cardiac death in the young age is on the increase. Everyone don't say you must be healthy, you go for a walk every day. It is no longer the case. It's really getting yourself thoroughly assessed. That is the way how you should approach these issues.
Okay, thoroughly access and screening is the key of prevention. But so this bringing to our next question. Are there any telltale signs, of a healthy and fit individual that might indicate higher risk of suffering from heart attack?
Okay, so then it goes back to the risk factors. So if you remember one of the two of the slides that I showed earlier, risk factors that contributes to the development of heart disease. These are the things that's been bombarded. I'm pretty sure you probably remember by now. So obesity, high blood pressure, high cholesterol, high sugar, history of smoking, history of alcohol, family history of heart disease. If you were to have these as a boxes, like a checklist, these are the things that you can download. So in fact, you can just go Google risk factor for heart disease. The Google will then list you all the risk factors. Now take a pen, pencil, paper and start ticking the boxes. If you have not ticked any of the single boxes, what it means really, maybe your risk is very low. So it says lack of exercise, but you go for exercise every day. Excess body weight, your body weight is only 50 kilograms. Your height is about 1.68 meter. That means your body mass index is normal. And then you measure your waist circumference, only 28 cm or 29 cm. And then you say, I never smoke. You check your blood pressure, it's only 110/80. The last time you check your cholesterol, only 2.1, the total cholesterol, for example. And your blood sugar, only 5.2. Then you say, none of these boxes are being ticked. But if you are someone who says obese, high cholesterol, high sugar, high diabetes, the last time you remember going out to the park for an exercise was 10 years ago, and then you look at your diet, and then you smoke, these are the risk factors that the more you have on your plate, the higher the likelihood of you developing heart disease. And the most important point to make here is that you see a lot of it, the one that I mentioned to you, is all involving lifestyle. And this is what the WHO has recommended, that all this can be managed with lifestyle alone. In fact, you probably recall there was a lot of stir in the media about people going for bariatric surgery. So these are excessively obese individuals. So you can speak to my colleagues, Datuk Nick Rizza, who has been managing patients with morbid obesity. So these are the one whom the body weight is 120, 140 kg, 160 kilograms. And if you look at their medical history, all of them has high blood pressure, high cholesterol, and high sugar. And most of them certainly are on at least 5 to 10 medications And this is the interesting, funny part that I think maybe it's explainable. As their body weight come down, say from 120 to 90 kg, you will see that the blood pressure also naturally come down, that I have to reduce the amount of medication. So maybe they were taking 4 tablets for blood pressure medication that we have to reduce to 2 blood body weight, optimal body weight, say about 70 kg. Their blood pressure becomes so low that I have to stop all their medication. And this is applicable to the blood sugar too. I've seen patients whom are quite obese. As soon as they reduce their body weight, the medication requirement also reduces, the kidney function also improve. So that support the argument that you can actually control it without medication. But of course, this is in a situation if you have those risk factors as a contributing factors, predominantly obesity. So don't stop your medication alone today. Now I've said this because I don't want you to get me wrongly. Now the message here is that a lot of these high sugar, high cholesterol, high blood pressure are actually contributed by our own lifestyle. The more, but at the end of the day, it's all a trade-off. Kan? What kind of outcome you want. But if you lead only a healthy lifestyle, also very stressful to some people. So you need to have some coping strategy. So what you do is, if that day you really want to eat that special donuts or pao or whatever that you really want, that nasi kandar, you really wanted it, then maybe what you should do is in the morning you go jog for 35 minutes, and then breakfast you have very healthy breakfast, then afternoon you go for your nasi kandar, evening go for your jog again. So what you do is, you whatever you put in, you burn. So this is some of the tactic and strategy. The strategy number 2 is really about the portion. So you see how the Angmo lifestyle, when they go fine dining, very small portion, big plate, small meal, very expensive, very fine food. Maybe you should consider doing that too. So instead of getting a tub of chocolate ice cream, go for the most expensive ice cream that you can get for 1 scoop. That way you justify it's worth it to take up these extra calories and burden is worth it, and then later you go for your exercise. So these are some of the things that you can do to cope with the demand. I mean, especially for Malaysia, we are the heaven of the food for the world. To just eat oat every day, I think also very stressful and horrible life. That's not what I ask you to do. So I would say balance your diet, try to make it more interesting, put more colors, more vegetable, more fruits, try different things, eat like the Greeks and the Italians, because they don't have so much of the simple carbohydrate. If you really have to go for the rice, maybe go for it, maybe do it once a week, but explore, be creative, try other meals in other cultures, diets also, to diversify. By doing this, I think hopefully, and we can remind each other So next time you makan, your friend remind you, don't get angry. Then you also remind your friend, and it's actually for the benefit of all. The more we remind each other, the better. And sometimes I realize also for me every time when I preach like this to the patient, actually it's for myself also. And I tell you, if you should really follow how the doctors go for their meal. For makan-makan among the doctors, then you'll be surprised. I've been approached many times when I eat at the Gleneagles cafeteria. Some patient come and just drop by and say, "Doctor, I know your doctor here. I just want to check what you eat." I tell you how embarrassed I am sometimes. So really, these are the things that you need to strike a balance. So just like your share in the market, sometimes go up and down, up and down, up and down. That's the same with the motivation for us to be healthy, goes up and down. But as long as the trending is to the betterment, is good. Don't trend downwards all the time. Not good. So as long as creeping up, making that progress in terms of being healthy, I think that's good enough. No point of suddenly one day go up and then next day crash all the way down. That's horrible. You'll avoid this counter anyway. All right.
Yes, doctor. Very good. I love your sharing, because after all, we are humans. Sometimes we have our emotion and our cravings, but I like the idea of working very hard so they can have a nasi kandar and then exercise again to burn the fat. Very good. Okay. Next questions. I'll try to go through question quickly so that we will end accordingly. What are the current guidelines for elderly aged 65 and above on optimum systolic pressure, diastolic pressure, and pulse rate?
Okay.
When is medication considered necessary? Yeah.
Okay, so this is very interesting. If you look at the guideline, there are two big guidelines. They are a bit separate. So you can either follow the American guidelines, so the American Cardiac College of Cardiology, ACC, AHA, American Heart Association, or you can follow the British guidelines, so the British Heart Foundation. But the magic number is 130/80. So 130 is the upper reading. So how do we measure it? When the heart is contracting, so that's the pressure when the heart is contracting. And then the next cycle is when the heart is in relaxation. So that's the bottom reading. So you get 130 at the top and 80 at the bottom. Sometimes when you do this blood pressure machine at home, there's a third reading. So that's your heart rate. So don't get confused. So heart rate is how many times your heart is beating per minute. So the majority of people, the recommendation is 130 for the top, 80 for the bottom, and below. So if your blood pressure is say 118/72, so that's normal. Now we are touching the level of hypertension when your blood pressure is above 140/90. So this is the other magic number that I want you to remember, 140/90. If the reading is say 145/98 or say 140/100, that means you already have blood pressure stage 1. And what do? When you see me the first time, I normally don't prescribe medication because I don't like to chuck in tablets. Chucking tablets is easy for me. There's so many tablets to choose in the market. It's like kids having a choice of what to throw to this patient. But I don't like that approach. Normally, I'll tell them to go home, do blood pressure assessment at home, and do all the lifestyle changes that we talk about. And majority of patients, about 50%, will come back, doesn't need medication. All they need is just to try and sustain and maintain that healthy lifestyle to bring down their blood pressure. And I think this is very important. Sometimes the doctor wanted an easy way out and wanted to impress the patient. And they say, take this tablet, your BP will come down. Sure, you take the medication, sure the BP will come down. Because this medication will work in various ways in terms of dilating your blood vessel, reducing the mean arterial pressure, many mechanisms to reduce the blood pressure, sure. But this is not the best way forward. So I think for those young ones, first step is to look at the lifestyle and do all you can to reduce the lifestyle. You'll be surprised by cutting down just 5 grams of your salt intake can reduce your blood pressure by 5 to 10 millimeter mercury. By doing 30 to 45 minutes walk per day every week, and you sustain that every week, that can also from the data shows that your blood pressure can reduce by 5 to 10 millimeter mercury. Reduction of weight by shedding off 1 to 2 kilograms can bring down the blood pressure by 5 to 10 millimeter mercury. So what it means really, there are some other methods to reduce blood pressure. But of course, many people don't like the hard way. They want the easy way. Doctor, give me the tablets, bring it down. In such case, I will give, but I will also encourage with the view that if we can try to reduce the dose and wean off is better. Now, for those above 65, so this is the special group, those who are above 65 years old. So somehow in 2017, the Hypertension Society has made some adjustment. And the adjustment is that the blood pressure for them is between 140 to 150, the upper limit. Why? As we get older, the aorta, the big pipe of the heart becomes stiffer. When it's stiffer, the pressure naturally goes a bit higher. So for this group of patients, I don't go gung-ho to bring down the BP so much. So we are trying to aim for 140, 150 for this group. However, if they have a presence of diabetes, we want to bring it down maybe a bit more towards the 135, 140. Why? Because if you have diabetes on top of high blood pressure, the risk of you developing heart disease and the problem that comes with it actually much higher than your counterparts who don't have diabetes. I think the key here is that there are various ways for doctors to check if your high blood pressure truly has caused trouble or not. So in an uncontrolled hypertension persistently throughout, you will see that one of the effects is it makes your heart muscle become thickened. And how do we do this? By measuring it on the echocardiogram. So we do an echo, check how thick the heart muscle less than 1 cm, no, I will allow the patient to have more time to do lifestyle. But if I see that the muscle has become very thick, the ECG also shows an evidence of something to be aggressive. So we need to deploy quite a lot of medication just to bring down the blood pressure to a safer side. So this is how I decide.
Okay. All right. Thank you, doctor. I hope that answered question to our guest asking for above age 65.
Yeah.
We have a question by our guest is, has having heartburn when wake up in the morning but go away later in the afternoon, is that a concern?
Oh, heartburn, is it?
Yes, heartburn.
Okay, so interestingly, when it comes to heart symptom, usually it makes worse by exercise. Why is that? So you imagine the is act as a pump. So when we exercise, our organ of the body require more oxygen and blood supply. Therefore, the heart has to work harder. The heart rate of the heart increases, so the requirement by the heart muscle for oxygen and blood supply is much more. So it is during this period, if you have a narrowing, it will not allow enough blood to flow through, then the heart muscle will be deprived of oxygen. This is the point where you'll be very symptomatic, meaning the symptoms will come lah. Having said that, there are some people who have diabetes. This is a bigger problem. Diabetes numb all the nerves. So the symptoms all go haywire. You can't really tell. There are people who have diabetes and heart attack and they don't even know. And there's a terminology of this inside the textbook. So it's called silent infarct. Very scary, having a heart attack and not knowing that you have it. And that's the worst part lah. So for me, if you have heartburn in the morning, and then it goes disappear in the afternoon, possibly maybe it is due to indigestion and heartburn or reflux disease. But in order for you to make a diagnosis of reflux disease, usually you will need a scope. So if the doctor scope notice that the stomach is completely normal, sometimes they take this sample called flow test, because especially for the young ones at the age of 35 to 45, there is a special infection of the stomach called Helicobacter pylori that causing you to have this indigestion and heartburn or heartburn. This can be treated and can be diagnosed with a scope. But if they do the scope is normal, then maybe it's time to check why you keep having that symptoms there. And as I said to you, look back at your risk factors checklist. Are you a smoker? Yes. When was the last time you go for exercise? No exercise. Is your blood pressure high? Yes. Is your sugar is elevated? The last time you checked, it was 7.9. So it's yes. Do you have high cholesterol? Yes. If you have so much symptom, so much risk factors, checklist tick. I think doesn't matter what symptom, you better get yourself checked, because these symptoms may be atypical, especially for ladies. Remember, the ladies only 30% have chest pain. But more than 40% complain of epigastric discomfort in indigestion, which could be a symptom. So the key here is not to guess what it is, but to confirm and check what it is.
I guess the most important is to speak to a doctor to get a proper diagnosis, whether get a scope, because heartburn could be many other issues. I've just checked that we actually have 18 questions lined up. We may not be able to answer all because, Doctor, you are a very popular speaker. Okay, but for those who have put in their questions, not to worry, I will forward them to Dr. Akmal later.
Sure. Yeah.
Perhaps you just answer final two questions.
Yeah.
Which is related to vaccination.
Okay.
What is the comment about having heart issue with vaccination at this point in time, especially for those above age 60?
Yeah. Okay. So you probably have heard. I mean, I got a lot of questions, and in fact, I've made this special letter in my clinic lah. Because I have a lot of patients who already had a heart attack, already had stenting, on various amount of medication, and particularly blood thinning medication. And there are different types of blood thinning medication. There's the cardioprin aspirin, there's the clopidogrel. There's also the blood thinning medication called warfarin or oral anticoagulation such as Pradaxa or dabigatran. So all of them are very worried, because if you heard, I mean, I'm pretty sure not just in this particular group, I also participated in some of the WhatsApp group. You cannot believe it. The amount of information being shared in the WhatsApp group is just, it's crazy. Sometimes at 1 o'clock in the morning, 5 o'clock in the morning, sometimes random odd hours, I'll have all sorts of professors giving opinion on the WhatsApp group. And I can tell you, for my family members, even my parents and my parents-in-law, everybody all scared to take vaccination. Everyone is scared. This is despite me telling them all sorts of information and they are still scared. So I appreciate the concern. I mean, for Malaysian patient lah, I think for us, this is all new. So I totally understand. I mean, this COVID-19 now is 2021, right? Almost half of the year. Later it will be 2022 and still we are stuck in this COVID 2019. Very painful fact. Everyone is traumatized, including me, everyone, all of us. So I truly appreciate. But fear should not be mixed or preclude your judgment with knowledge and information. So again, what is important is to deal this issue with facts. I remember in the beginning of the lockdown, a lot of people. The best example of this is to talk about shares lah. I don't play shares, but I heard people talk about it. So a lot of people buy the counters on the glove market, and so people because of fear lockdown, they sell certain counter, they buy certain counters out of fear. But those who have knowledge will stay put and follow the company based on knowledge. Those who don't follow knowledge and follow fear, all sure will not do so well. I think in terms of vaccination, we should separate our anxiety and fear and deal only with information. If you ask me personally, at present moment, there is no definite contraindication. If you have heart problem, taking blood thinning medication, nothing to say you should not take vaccination. In fact, the general consensus is due to the severity of symptoms of COVID-19 when patients are affected by it, especially those who are above 60, the elderly group, when they are infected by COVID-19, the risk of them dying is high. And COVID-19 is a very dangerous condition because it spreads to the lung so quickly, inducing damages to the lung function. And I can share with you some of the cases that I have been managing for COVID-19, that the amount of rapidity, how rapid this COVID-19 spreading in the lung is very scary. You can see the chest x-ray on day 1, followed by day 3, spread to the other side of the lung, followed by day 5, the whole lung is totally shut down and the patient are intubated and ventilated. It's very scary, and the amount of death that is causing, it's also worrying. Now, what can we do? So COVID-19 vaccination is one of the way to protect ourselves and our family. So not just you, so it's also the nearby family. And how does it do it? So my analogy I tell the patient is that COVID-19 is like a tiger, like a tiger. So vaccination is a way of introducing your body to this picture of tiger. So they will chop off the tail of the tiger. So that's the vaccine. Put it, inoculate into your body. So the immune system of your body will then identify, hey, that looks like a tiger, because they see the tail, but not the actual tiger. So it's actually harmless. They see the tail, then your body immune system, the humoral system will start to develop all these antibodies, so that the next time when the real COVID comes in, the actual real tiger come into your body, the immune system already prepared. The likelihood of this viral to replicate and cause you such a severe symptoms will not be possible, because the immune system already recognized, rather than someone who doesn't know what it is. So can you imagine the actual COVID comes in, but you've never been exposed to it? It takes a long time for you to develop the response. And therefore, you may develop severe symptoms. And the severe symptoms come through to individuals with comorbidity. And the comorbidity is if you have diabetes, obesity, heart problem, kidney problem, liver problem, all these underlying problem, if you already have, it makes you at the group who will do much worse. And those group who you see in our country data, those who are intubated and ventilated, in the beginning, we see that the group are in the elderly, much older, but now we are seeing the younger group being intubated and ventilated. And there's something called the strain and variants that we keep hearing again and again, that this virus are also go into mutation, trying to differentiate itself and able to pass the loops. So for me, the take-home message here is any form of vaccination is recommended. the risk when you take the vaccination is low comparison to the benefit that you will gain in terms of protection of COVID. Now, the next question is which vaccination to take. I think right from the beginning, you see lah our arrangement for vaccination lah. So this is recorded, so I need to be careful. You know, in terms of the arrangement, whatever that comes first, that to you, that you can access, that is the right vaccine for you. That's my answer. So I think in the beginning, the deployment is with Pfizer, which is the mRNA form of vaccine. This is from the United States. It works in a different way. You probably still heard people have some side effect, but the number is very small. Now, you probably say, doctor, I don't want to take the risk. Therefore, I don't want to get the vaccination. I say to this group of patients, can. If you do not want to take the vaccine, what you do to protect yourself is isolate yourself. So meaning you must stay at home. Don't go out. Don't have any contact with any individuals. And if you can keep this distance and keep yourself at home for as long as you can and not go out at all seeing any people, and wait until the rest of the herd immunity or the majority of the people has been vaccinated and case and come down, then you can come out from your house. I think that's also a fair strategy. But can you afford to do that? If you can, go ahead. So maybe order something online, ask them to leave it at the front door of your house. Don't go out until 2030. You see how years. With the current rate of our vaccination, how many years? 10 years, right? UK will reach herd immunity in 9 months, I think. I heard. US also in the next few months. I think it's the same with some of these European countries because of the rate of the vaccination is huge and fast. So they can afford to come out of their cave in the next months or years, 1 or 2 years. But for you, if you're planning to stay in your cave for another 10 years, then go ahead, that's the strategy. But otherwise, if you need to meet up with people and go out, which I think this is what we need to do, then vaccination is the way to go. The next vaccination that has been offered, I think was done as an online first come, first serve basis last Sunday. This was with the AstraZeneca. A lot of people ask me this question. On that day, my phone was bombarded with all the relatives, even no relative also bombarded. But I answered the question lah. Number one, they compare the price lah. Oh, you know, Malaysian to pricing, they think the more expensive, more cheaper. So some say dial dose of per Pfizer cost $20. Cheaper means bad. No, not like that lah. So AstraZeneca is developed together with Oxford. I know maybe most people don't recognize Oxford as a top institution, but I still do. At least they are one of the top 5 universities in the world. And then these facilities that produce this vaccine has got 2 in UK. So one in Oxford, the other one is in Kiel. So your vaccine doesn't come from dodgy factories in some remote part of the world. And number 3 is that the amount of vaccination that has taken place in UK is 38 juta, 38 million individuals. When you hear that number, you feel like, oh, that's a lot. That is a lot of numbers, 38 million. And if you look at those numbers also in Australia, I think I do not know what the arrangement they have. Majority of the Australians, in terms of the vaccination, also they have received the AstraZeneca. Yes, there is a risk of clot, especially in the younger individuals, not so much in the elderly. So answering your question, those who are above 60, if they sign up for the AstraZeneca, will there be an issue? The answer is no. What if it comes with the Pfizer? Also no. It's only for the young ones. So if you are in the younger age group and you have a lot of this history in the family, say of clots in the lungs or clots in the legs, or you yourself already had a clot before, and then you also have all sorts of allergy. You're allergic to strawberry, allergic to peanut, allergic to seafood, allergic to this and that, everything you're allergic to. So these are the group that we say maybe you can consider delaying your vaccination. But for the rest of us, I don't think so. I think Malaysia, whatever that moves and have some color, we eat. We eat everything. So if that's the case, it should not be an issue. But the key here is that once you've taken the vaccination, you get yourself checked. If you have any symptoms, just come and present it yourself. And then, of course, there is a way to get yourself. In fact, I can recall for our hospital in Gleneagles, we are proud to say that we have kind of vaccinate most of our workers, and not just doctors and nurses, the front counters, the ladies, whoever. In fact, I was quite surprised, even the cleaner also vaccinated. Why? Because they walk around in various regions. And the good thing about having vaccination is that the likelihood of you being a carrier to get infected and carry, and known as, this term called the super spreader. These are the one, they're fit and young. They harbor the virus and they go around spraying it everywhere. So by vaccination also, you're reducing your chances of that. Okay. So for me, the earliest vaccination that you can get your hands on is the most important. The risk, the benefit of the vaccination outweighs the risk significantly. If you have some risk factors, then you want to get yourself checked, feel free to come and get yourself seen and assessed. In fact, the KKM and the WHO has given some guidelines on what are the checklists that you can go through and get yourself assessed. So to put a point blank of saying that vaccination is very dangerous, don't do it. Sometimes I see these individuals, they even dare to do other things that is more dangerous to them. Those electric cigarette, the e-cigarette that they suck into their body day in, day out, the smoking, these are the far more dangerous and more toxic. They never question about the evidence. But for vaccination, for us, this is proven strategy. If you remember, when you take all your babies to see the pediatrician for vaccination, this is the same concept of inoculation. We've managed to keep all those dangerous diseases like mumps, measles, rubella at bay because of the vaccination. And this is not much difference of a concept. And I think everyone had enough of being locked down again and again. I think the vaccination is one of the way. I mean, we can't save the whole country doing this, but one of the few things that we can do at least is to save those who are around us. So if you ensure that your family, your relative, your neighbors all get vaccinated in your region and area, then you know that neighborhood are all safe. If you know most are vaccinated. I hope this answer your
Thank you,
question.
Doctor.
Sorry, such a
Yes,
long
yes.
answer.
I
think
agree
I
that.
needed to emphasize this.
Yeah, vaccination is really important for us to actually stop spreading this COVID-19, and hopefully we will end this soon. Just one question that's related to vaccination. We have a guest that asked that, I'm living with pacer. Do you recommend, is it okay to take vaccine?
Oh, for pacemaker?
Yes, that's right.
It's not a problem. It's not an issue. The key is that if you have concern, so you need to go see doctor for your pre-vaccination assessment. And then post-vaccination, don't stay alone. So at least have a mechanism of informing someone if you're not well. So if you have some symptoms, let it be body ache or fever or pain or breathlessness or lethargy, and you really want to get yourself checked, you can come. In fact, you can come to the hospital. The doctor can do simple tests like a blood test to see how your body response is. And some patients even get admitted for monitoring and assessment if they want. So these are some of the strategy that you can use. And don't focus too much on the small numbers of the one who have reaction. I always say that not all medication will suit everybody, but we still prescribe it because it has benefit. Say for example, you have heard some people say, oh, I have this allergic to peanuts. You can imagine, like, you'll be scratching your head. Allergy to peanut is crazy. Like, how many million people eat peanuts every day? And yet, for those people who have peanut allergy, they will have reaction. So what it means is you need to check if you have a lot of this history of allergy, this and that, maybe you can have an assessment before. But majority of us should be benefiting from vaccination, should be benefiting not only for us, but for the rest of the family.
All right, thank you so much again. Thanks again to Datuk Dr. Akmal for sharing with us today. Thank you so much for being with us today on a Sunday. Okay, I know that probably now that it's a good time for us to end. We have a lot of questions that have been lined up. Okay, today has been a very popular talk for Dr. Akmal. I will forward the questions to Doctor after today.
And no problem. So I promise I will get back to you on all these questions. Yes. I will liaise with Sarina. We'll get all the question list, and then we will answer to them directly lah. Maybe if they leave either an email or phone number, we can just message them back. Yeah.
All right, I'll do that. Thank you so much again, Doctor. And we're very proud to be together, working together with Gleneagles Hospital, Kuala Lumpur. I saw that in their social media that they have vaccinated everybody in the hospital. Wow, that's amazing. Right, so you can see in front of the screen, Dr. Akmal Arshad's information on his office phone, and also his with Gleneagles that you can make an appointment on their website. This is from Gleneagles website. Next, we have a feedback form. Please take your phone to scan the feedback and tell us what do you like about our session, especially with Dr. Akmal today. Okay, our partner working together with Gleneagles, please like their social media website on Facebook, Instagram, and LinkedIn, and you get to see a lot of updates from the hospital. Okay, we have been very thankful and privileged to work together with the marketing team that has been with us since last year. This Pioneers Financial Health Talk that has been ongoing since the first MCO back in April 2020, and today is actually our 21st episode. Oh. So thank you so much for our guests who has been with us for so many months and months coming back. We will continue to our monthly health talk for everybody's benefit. Okay, so the Pioneers is together with Prudential. We are partnering with Prudential and Prudential Takafu, and very proud to say that Prudential is one of the LinkedIn 2020 top 100 companies. Okay, and Prudential is launching a new plan called the Pru Cash Enrich. Speak to your friendly wealth planner to find out more about it. And for our next talk, it's going to be on the 6th of June, Sunday on 3 p.m. Mark your calendar. You can register immediately. Unfortunately, we don't have the topic and the speaker available at the moment, but we'll update everyone as soon as we can, as soon as we get it. Okay. All right. I'll show this in a while again later. Okay. And I'm here wishing everybody happy Mother's Day once again to all moms here, to all the wonderful moms, to your mother, okay, or your mother-in-law, and to all type of moms. And Selamat Hari Raya in advance for next week, because next Thursday is Raya. So maybe going to be a quieter celebration, but it's still a celebration after all. But most important, everybody stay healthy and stay safe. That's very important. Okay. And feel free to scan and like my page on Instagram and Facebook. Then we can get connected. All right. So with that, we'll end today's session. Thank you once again to everyone for being here today. Special thanks to Doctor once again. Thank you so much. Really appreciate your sharing for today. Thank you. Thank you, Sarina, for being with us, and to our co-host for managing today's talk. Take care, everybody. Have a fantastic rest of the weekend. Okay, stay safe and take good care. Thank you so much.
Thank you.